What kind of joint it is? Fibrous joint. Is it fibrous joint? It is fibrous joint.
Synovial joint. Synovial condylar.
Temporomandibular.
Type is type. Synovial joint.
Subtype
Condylar.
condylar. Very good. This is called condyle. This is called condyle, and this is called mandibular fossa. So, first of all, you will mention the bones participating in the formation of this joint. তাহলে কি হবে প্রথমে head of the mandible. Mandible হয়ে গেছে তো, ফর্ম হয়ে গেছে তো। This is the head of the mandible, right? This is, what is this? This part? This part?
Mandibular process.
Coronoid process, very good, fine. সেটা পড়ছে। So, this joint is synovial joint, condylar variety, right? Now, what are the ligaments? After mentioning the bones, then you have to mention the ligaments. What are the ligaments that present around this joint? One is lateral temporomandibular ligament. Lateral temporomandibular ligament. Right? So lateral means it should be at the lateral aspect, and medially. Before that, I forgot, and I have already told you. First of all, in any case of synovial joint, first ligament is capsular ligament. First, you should mention capsule of the joint, capsular ligament. Then you should tell lateral temporomandibular ligament. That lies laterally. Medially, there are two important ligaments. One is sphenomandibular ligament and stylomandibular ligament. Sphenomandibular ligament and stylomandibular ligament. Now this sphenomandibular ligament, from development point of view, very important ligament. Though it offers very little stability to this joint, but embryologically it is very important. This is sphenomandibular ligament. It is coming from the spheno, means sphenoid. Mandible means mandible. Sphenoid from the spine of the sphenoid. So for the time being, you remember spine of the sphenoid. From there, this ligament comes and attaches to the, here it is not present. There is a mandibular foramen on the medial aspect of this. On the mandibular foramen, there is a spicule of bone that is called lingula. Lingula. So it is attached to the lingula. What are you saying? Sphenomandibular ligament. From where to where it is stretches? First, from the spine of the sphenoid to the lingula of the mandibular foramen. Why it is important embryologically? Because it develops from the sheath. It develops from the sheath of the first branchial arch. It develops from the sheath of the first branchial arch. Now, stylomandibular ligament. That is sphenoid. Another ligament. There is a stylomandibular ligament. From where it is coming? Stylomandibular ligament. From the stylo process to where? Which part of the mandible? No, which part of the mandible? Mandible to pura. Which?
Coronary process.
Coronary process. Angle of the mandible. From the styloid process bhi hai nahi. From the styloid process to the angle of the mandible. This ligament is coming from which structure? This is stylomandibular ligament. I have already completed this part. Very good, fine, good. Investing layer of deep cervical fascia condensed to form stylomandibular ligament. So sphenomandibular ligament is the embryological remnant And stylomandibular ligament is the condensation of the invasive layer of the cervical fascia, which stretches from the lateral aspect of the styloid process to the angle of the mandible. This ligament, stylomandibular ligament, it actually differentiates, but in front of it lies the submandibular salivary gland and behind lies the parotid gland. So it is the demarcation line between the submandibular and parotid gland. So these are the two ligaments that lies on the medial aspect, and laterally lies the only one important ligament, that is lateral temporomandibular ligament. Now with this knowledge in your background, I will now draw the picture. This is mandibular fossa, and this is the condyle of the mandible. This joint is completely separated by a fibrocartilage. Fibrocartilage. This mandibular fossa, you have already completed the mandible, and this is the mandibular fossa. Actually, it is the part of the temporal bone. It is a temporal bone. It is anteriorly. This part is known as articular tubercle. Both say this part is known as, this is the anterior part, and this is the posterior part. Anteriorly, this raised area is known as articular tubercle, and posteriorly is the postglenoid tubercle. Now, the fibrocartilage, which is actually dividing the dividing this joint cavity into two parts. Here you see this fibrocartilage is from anterior to posterior. First of all, you consider this fossa. Mandibular fossa is actually, this is the concavo-convex. This mandibular fossa is concavo-convex. And to feed the fibrocartilage, here you see it is concavo-convex from anterior to posterior. And this is concavo-convex from posterior to anterior. Do you follow? To feed this cartilage, the bone is, mandibular fossa is concavo-convex from posterior to anterior. And this ligament, the fibrocartilage, articular disc, this is, its upper part is concavo-convex from anterior to posterior, and lower part is only concave. So it is dividing the joint cavity into two parts, upper part and lower part. Lower part is concave, or upper part is concavo-convex, right? Now this fibrocartilage is attached to the capsular ligament. This is the capsular ligament. So it is attached to the capsular ligament. Here lies the head. Here lies the head. Now, what is the function of this articular disc? It is fibrocartilage in nature. What is its function? Its function is it provides congruity. What is the meaning of congruity? What do you mean by congruity? Congruity means, suppose if there is big difference between the fossa and the head, then it will be movable. So to prevent this onward movement, if it is tightly packed, if a joint is tightly packed, then there is less chance of dislocation. So this tightly packed condition is known as congruity. If this term is not remembered, we should say that it makes the joint tight. This fibrocartilage makes the joint tight. Now, this joint, temporomandibular joint, sometimes patient may come to you with dislocation of the temporomandibular joint. If there is dislocation of the temporomandibular joint, then how will the patient present to you? If a patient comes to you with dislocation of the temporomandibular joint, how will the patient present? With open mouth? He will not be able to close his mouth. He will not be able to close his mouth. When it occurs, sometimes our temporomandibular joint dislocates. When it occurs, if you excessively open your mouth, excessively, মোটা একটা হাড্ডি খাওয়ার সময় it may displace, or at the time of yawning, when you are yawning, that time it may dislocate. After this dislocation, you have to know the mechanism by which you can reduce this dislocation. I will come to this part later. Now, so this is the main objective is you know the competence based education. What do you mean competence based education? You should be competent. My role is as a teacher, my role is facilitator. I am not information giver. I will give you information and you will jot it down on your paper. It is not my job. You should ask me question and you have to be competent. After this class, you should be competent enough to know about this joint and you will be able to show. If this type of patient comes to you, you will be able, after this class, you will be able to reduce this joint, dislocated joint, right? So now this joint cavity is divided by a fibrocartilage, that is articular disc. Upper compartment and lower compartment. At the upper compartment, what type of movement occurs, and in the lower compartment, what type of movements occur. At the upper compartment, the movement which occurs is the gliding movement, glides. And the lower compartment, there will be rotator movement. At the lower compartment, there will be rotation, and at the upper compartment, there will be gliding. Right. Now, suppose if you want to open your mouth. Now, before that, I have to tell you one point. At what position of mouth this joint is most stable? At what position of the mouth this joint is most stable? Follow.
When the mouth is closed.
Closed, very good. When mouth is closed, when you are touching both teeth, at this position, this joint is most stable. बॉक्सिंग देखा? बॉक्सिंग तो वो जो है ना, जो बॉक्सर एक चीज़ देखे ऐसे करके दांत तो करता है, नहीं एक ब्लो यहाँ पे लग गया तो डिस्टर्ब हो जाएगा, राइट? एट द occlusal position, this is called occlusal position, this joint is most stable. Now if you want to open the mouth, first what will happen? First there will be forward movement. This forward movement is known as protraction or protrusion. This forward movement, when the lower teeth is moving forward, this is called protraction or protrusion, and backward movement is retraction. So if you want to open your mouth, there will be first protraction, then there will be opening, depression. First there will be protraction and then there will be depression, right? And if you want to close the mouth, just reverse should be done. First there will be retraction, then elevation. This clear? So if you want to open your mouth, first there will be protraction, then depression. And if you want to close the mouth, first there will be retraction and then elevation. Now you should know what muscles actually causing this protraction, which muscle is causing retraction, which muscle is closing the mouth, and which muscle is opening the mouth. Right? Now this protraction and retraction occur in the upper compartment. This articular disc divides the mandibular fossa into two compartments, upper compartment, lower compartment. Upper compartment is known as menisco-temporal compartment and lower compartment is known as menisco-mandibular compartment. Right? So menisco-temporal is the temporal bone, fossa is temporal bone. This fossa is very wide area. Its anterior part is articular and posterior part is non-articular. Right? Its anterior part is articular, posterior part is non-articular. Right? Now the muscles, you have already heard the names of muscles of mastication. Right? What are the muscles of mastication? One, masseter. Two, buccinator is accessory muscle of mastication, not primary muscle of mastication. What are the muscles of mastication? Number one, masseter. Number two, temporalis. Very good. Temporalis.
Medial pterygoid.
Very good. Medial and lateral pterygoid. There are four muscles of mastication: medial pterygoid, lateral pterygoid, masseter, and temporalis. Right? All these muscles of mastication is supplied by which branch of the cranial nerve? এগুলো একদম, it will be at the tip of your tongue. All these muscles are supplied by mandibular division of the trigeminal nerve, because these muscles develop from the first branchial arch, and first branchial arch, the nerve of the first branchial arch is mandibular nerve. That's why all muscles of mastication should be supplied by mandibular division of the trigeminal nerve. Right? Now actions of the muscles. What are the muscles that cause protraction? What are the muscles that cause protraction? Bolo. One muscle is coming. Here there is a fossa. This is called lateral pterygoid muscle. Lateral pterygoid muscle is attached anteriorly to the neck of the mandible. Anterior aspect of the neck of the mandible, there is a fossa. There it is inserted. It is coming from anterior aspect, right? So if it contracts, what will happen? It will move forward. It to samne se acha na, if it contracts, then it will move forward. And this is the ramus of the mandible. On its medial aspect, there is the insertion of the medial pterygoid. So here there is medial pterygoid, like this. Here there is medial pterygoid, and here lies, on the outer aspect lies masseter. On the outer aspect lies masseter. So here lies masseter. So medial pterygoid and lateral pterygoid, if they contract both jointly, they will protract the head of the mandible. So protract is done by the pterygoids. Pterygoids mean medial pterygoid and lateral pterygoid. If you know the mandibular attachment, then you will be able to appreciate the function. It is coming from forward and inserting into the medial pterygoid or the medial aspect of the ramus of the mandible, and lateral pterygoid in front of the neck of the mandible. Right? Now another muscle that is called temporalis. Temporalis is a big muscle, fan-shaped muscle. It is actually inserted into the coronoid process. So its posterior fibers. Now I am talking about the retraction. Posterior fibers, here lies the temporalis. Its posterior fibers causes the retraction of the head of the mandible. So it is the retractor posterior fibers of the temporalis. Along with that, you have already seen, suppose this is the masseter, here lies the hyoid bone. From a hyoid bone, this muscle is the, what is the name of this muscle? What is the role of this muscle? It is coming from the anteriorly digastric. Another muscle from here to here, that is geniohyoid. So these muscles, if contract, it will also draw the mandible backwards. So geniohyoid, mylohyoid and digastric also helps in the retraction of the mandible. The first you will mention, the main retractor is posterior fibers of the temporalis. Then you should mention the other muscles, that is suprahyoid muscles, number digastric and geniohyoid. Right? So retraction and protraction. What is the, whenever you will mention any movement, you have to mention the axis of the movement. Here the axis of the movement is transverse axis. Now, this transverse axis is not fixed axis. This gliding movement, transverse axis is not fixed. It also moves with the muscle. Right? This axis is transverse, like this. Along this axis, this gliding movement is occurring, but this axis also moves with the retraction or protraction. Right? Another movement is there, that is rotatory movement, hinge movement. There is another movement, hinge movement, that occurs in the lower compartment. Here there are two compartments, upper compartment, lower compartment. At the lower compartment occurs the hinge movement. That means this rotation. When you are opening or closing the mouth, it is opening, and this also occurring at the transverse axis, and that axis is passing through the mandibular foramen. If you connect two mandibular foramen along this transverse line, this opening and closing movement will occur, and that is the fixed transverse axis, and that movement is occurring at the lower compartment. You will remember this. The opening and closing, this movement, rotatory movement, is occurring through a fixed transverse axis, and that axis is passing through the mandibular foramen, and that movement is occurring in the lower compartment. That is menisco-mandibular compartment. And upper compartment is a menisco-temporal compartment. They are occurring the sliding or gliding movement. That gliding movement also occurring at the transverse axis, but that transverse axis is not fixed, and it also moves. Movable transverse axis. So, if you are asked at what compartment gliding movement is occurring, at the upper compartment. What is the axis? Transverse axis. What is the criteria of this transverse axis? This transverse axis also moves along with the gliding. Number two, there is a rotatory rotation movement. When you are closing and opening the mouth, that is also occurring through the transverse axis. That axis is this fixed transverse axis, and it is passing through the mandibular foramen. Clear? Clear hua? All right. Now, there is another movement, side to side movement. Side to side movement, কখন করিস side to side movement? When you will do? Actually, it is done by cattle. Cattle तो जाऊर काटे ना. We generally do not use this movement, but you should know you can do side to side movement. When you do side to side movement, what will happen? At one side there will be gliding movement, on the other side there will be rotation movement. The gliding, suppose on the right side if there is gliding movement, then it will move forward and your chin will go to the opposite side. And if it is gliding movement, on the opposite side there will be rotation movement, and that rotation will be called vertically rotate. That rotation will be vertical axis. That rotation will be called vertical axis. It is occurring in the upper compartment gliding movement, and rotatory movement is occurring in the lower compartment. Right? বুঝতে পারলি? Side to side movement. And alternately act. Pterygoid muscle will alternately act. যখন এদিকে pterygoid muscle অ্যাক্ট করবে তখন এদিক করবে না, আবার এখানে এদিক যখন করবে তখন এটা স্টপ করে থাকবে, তবে তো ঘুরবে। Alternatively acting the pterygoids to cause the side to side movement. So these are the movements. What are the factors that give stability to this joint? What are the factors that give stability to this joint? Which, if there is excessive protraction, forward movement, who will prevent this protraction? The retractor muscle will prevent. Retractor muscle will prevent excessive protraction. That is, here you see, this is a temporal muscle, posterior fiber of the temporal. It will prevent the excessive protraction. And also there is a tubercle, articular tubercle, bony factor. There is a bony factor, articular tubercle, that will also prevent. So articular tubercle at number, it gives the stability of the joint. Piche there is a posterior tubercle, that also gives the stability of the joint. And that is the temporomandibular ligament. That temporal ligament is coming from forward to backward. So if you want to backward displacement, it will prevent. Right? তাহলে muscles, what are the muscles? Muscles হচ্ছে তোর একটা হচ্ছে তোর bony factor, first we mentioned. Bony factor হচ্ছে articular tubercle anteriorly, posterior tubercle posteriorly, these are bony factors. Ligamental factors হচ্ছে lateral temporomandibular ligament. Muscles, that is lateral pterygoid, and that is the temporalis. These are the muscle factor. They will prevent they actually give the stability to this joint, and that joint is most stable at the occlusal position when you are closing the mouth. Right? Suppose is half open mouth. If you give a blow to the chin, then there will be displacement. But if he clinches the teeth, you will not be able to displace the joint. Right? Now, what are the nerve supply of this joint? The nerves which lies adjacent to this joint, number one is auriculotemporal nerve. Auriculotemporal nerve, you know, just lies in front of the auricle. Auriculotemporal nerve and masseter nerve. These two nerves supply this joint, and arterial supply is the terminal division of the external carotid artery. What are that? Terminal division is superficial temporal and maxillary artery that supplies this joint. So arterial supply हो गया, nerve supply हो गया. Right? Now relations. It is to some extent difficult, but you will know that laterally this is, you can feel, if you open and close your mouth, you can feel the joint. So here lies the skin, superficial fascia, deep fascia, etc. laterally, and anterior lies this muscle, that is lateral pterygoid. This lateral pterygoid muscle, its characteristic is this muscle is also attached, blends with the capsule as well as the fibrocartilage, articular disc. So when this muscle will contract, it will also pull along with it this cartilage, articular disc. right? Anteriorly. Posteriorly lies this auriculotemporal nerve. Anteriorly lies one artery is passing through the mandibular notch between the head and coronary process is coming up the mesenteric artery, mesenteric vessels, and above the temporalis muscle is coming the mesenteric nerve. So there lies the anterior relations. Medial relation is to some extent difficult when you will study the infratemporal fossa. Within the infratemporal fossa, the structures which will form the medial relation. There is a spine of the sphenoid. That is spine of the sphenoid, very important Viva question, because spine of the sphenoid, on its lateral side lies one important nerve, auriculotemporal nerve, and on its medial side, one important nerve lies, that is called quadritympani nerve. So you are frequently asked, if this spine of the sphenoid is fractured, what will happen? If spine of the sphenoid fractures, what will happen? There is possibility of injuring these two nerves, quadritympani and auriculotemporal. Now their effect will be reflected on their supply. Quadritympani supplies the anterior to the taste sensation, so taste sensation will go. And auriculotemporal nerve, you know, it supplies the submandibular salivary gland, so there will be less salivation if that nerve is injured, right? So these are the medial relations. So in short, this is the temporomandibular joint. What are the questions? Now, actions. Which muscles will take part in opening the mouth? Number one, I have already told you, to open the mouth, first there will be protraction. सामने खींचना पड़ेगा. तो that muscle is lateral pterygoid. Then यहाँ से जो muscle attached है, digastric, they will contract. So digastric muscles, यहाँ से यहाँ तक जो muscles है, that is geniohyoid, तारपरे mylohyoid, they will help in the opening of the mouth. So first you will mention the lateral pterygoid, then suprahyoid muscle, right? Sometimes infrahyoid muscles also act. Infrahyoid muscles means those muscles which coming from, they actually, when suprahyoid will act, then it did that hyoid will move forward upwards to stabilize that muscle. Also infrahyoid muscle also will contract, so infrahyoid muscle indirectly also come into play, right? So this is the opening of the mouth. Now to shut the mouth, which muscles act to shut the mouth? Bolo. To shut the mouth. Huh? Masseter.
The mastication.
All muscles of mastication, ये रखना, all muscles of mastication helps to shut the mouth except lateral pterygoid. Except lateral pterygoid. All muscles help to shut the mouth except lateral pterygoid. Right? How this muscle act? First, I have already told you, if you want to shut the mouth, first there will be retraction. Retraction is done by the temporalis, posterior fiber. It is one of the muscle of mastication. And then upward pull of the masseter and medial pterygoid. They will close the mouth. Right? So these are the muscles will just shut the mouth. And what are the muscles that retract the mandible? Retract. और पीछे खींचने बोलो.
Digastric, posterior, digastric.
जो सबसे लेस इम्पोर्टेंट है ना, आपने जो है ना सबसे फर्स्ट वही मेंशन करता है. ये जो आपका ये है क्राइटेरिया, ऑल स्टूडेंट्स का क्राइटेरिया है, मेरा भी क्राइटेरिया यही था जो आई वाज स्टूडेंट. जो लेस कॉमन हो ना उसको फर्स्ट मेंशन करना. ये नहीं, आगे फास्ट जो है फास्ट मेंशन करना है। हमने क्या कहा, प्रोट्रैक्शन और रिट्रैक्शन कहा। अभी अभी जो आपने क्वेश्चन किया क्या कहा, रिट्रैक्शन प्रोट्रैक्शन। प्रोट्रैक्शन मीन्स सामने जाना, प्रोट्रैक्शन। तो सामने से खींचा कौन मसला है, पीछे खींचना जो है, पीछे से आ रहा है हमारा ये जो है टेम्पोरल से पीछे, तो टेम्पोरल का पोस्टीरियर फाइबर, उसका पोस्टीरियर फाइबर है, इसका सुपीरियर फाइबर खींचेगा तो ऊपर में जाएगा, क्लोज द माउथ। पीछे का फाइबर खींचेगा तो इट विल रिट्रैक्ट। सामने से जो मसल आ रहा है हमारा लैटरल टेरिगॉइड, लैटरल टेरिगॉइड सामने से इसको पुल करेगा, दैट मीन प्रोट्रैक्शन, राइट। तो ये बहुत इम्पोर्टेंट लॉन्ग क्वेश्चन from your examination point of view and from your practice point of view also. If patient comes to you with displacement of the mandibular, temporomandibular joint, then how will you reduce? Very simple procedure, and if you do not know, if you are a referring doctor, you should only refer to such and such doctor, such and such doctor. ऐसे करना पड़ेगा तुमको। अगर यू नो द मैकेनिज्म यू विल बी एबल टू रिड्यूस इट। नाउ व्हेन पेशेंट इज कमिंग with displaced temporomandibular joint, actually which muscles preventing the masseter and medial pterygoid, they are contracting, so you have to give pressure against them. So what will you do? After wrapping your hand with some towel, we will put your finger inside the mouth, just behind the mandibular tooth. Patient should be seated in front of you in a chair, and you will press the mandibular molar tooth downwards and backwards, and at the same time from this finger you will raise the chin upwards. ऐसा करोगे तो हॉट टाइम फटाक से वो रिडक्शन हो जाएगा 1 मिनट में, राइट। तो फर्स्ट ऑफ ऑल यू हैव टू प्रेस द बाय योर 2 thumb, placing the finger within the mouth cavity behind the last molar tooth. You will give pressure downwards and backwards, and at the same time you will raise the chin by your other fingers. Then it will suddenly reduce. পারবি তো রিডাকশন করতে এবার? বাড়িতে ধর একটা পেশেন্ট এলো তোর কাছে, হ্যাঁ, জেনারেলি তোর দিদিমা বা ঠাকুরমাদের এগুলো হয় আর কি, বুড়ো মানুষ তো মাসলগুলো সব উইক হয়ে যায়, হ্যাঁ, করে হাই তুলতে ফোন করে আর হা বন্ধ হচ্ছে না। আর তুই তো অ্যানাটমি জানিস, আর এখানে কোনো ভয় নেই বসো বলে একটু আশ্বস্ত করার পর হাত নিয়ে ওই নিচে গিয়ে খুব জোরে একটা নিচে চাপ দিবি আর এটা দিয়ে উপরে তুলবি, তুমি ঘাটাস করবি বন্ধ হয়। And what are the other applied importance? One is you have known the disease. One is known as tetanus. Have you heard the name of tetanus? What happens in case of tetanus? There is locked jaw. ये jaw lock हो जाएगा. The spasm of the masseter. There will be spasm of the masseter and there will be locked jaw. This is called trismus. Trismus. এটাকে বলে ট্রিসমাস। It is one of the manifestation of the tetanus. In Bengali, ধনুষ্টঙ্কা না শুনেছি, ধনুকম্প বেঁকে যায় আর হাসবে, মাঝে মাঝে হাসবে, হাসা নয়, ওই এটা কী বলে তোর রাইজোইয়াস মাসেলটা কন্ট্যাক্ট করে তো মনে হবে হাসছে, হ্যাঁ, রাইসাস সাডোনিকাস বলে রাখে, হাসছে মনে করে তো ভালোই তো হাসছে, কিন্তু যে ভেতরে কী হচ্ছে জানিস না, এই হচ্ছে ব্যাপার। সো তাহলে আজকে হয়ে গেল তোর টেম্পোরামেন্ডিবুলার জয়েন্ট।